so we will go ahead and get started. Good evening and good afternoon to those who have joined us today for our NHPA webinar. If we could move to the next slide, please. Okay, I would like to welcome all of you today to our webinar. My name is Lisa Serrano. I am the NHPA President-elect for this organization, and I'm also a pharmacy manager at City of Hope National Medical Center located in Southern California. I do want to go over some housekeeping items prior to us starting. The first one is that all participants' microphones will be muted, but we definitely encourage you to type in your questions into the Q&A box for the panelists and for Dr. Manzor, and we will go through them at the very end of the session. We also will request that you fill out a short post-webinar survey that will be emailed after the event. We will also show a QR code at the very end. Our recording will be housed on the NHPA website. It'll also be sent out 1 week after the event. Next slide, please. This webinar is offering a 1 hour CE credit through the University of Rhode Island. And we do want to note that participants will only be sent the CE credit for those who attend the full hour. So there will be no credits or no partial credits received for this webinar if any participation is less than 50 minutes. All of that information will be provided at the very end of this presentation. Next slide. So with that, I would like to introduce our topic today, which is depression care and Latino-specific social determinants of health, presented by Dr. Beatriz Manzor. Dr. Beatriz Manzor completed her pharmacy training, which includes her doctorate, PGY1 residency in pharmacy practice, and a postdoctoral research fellowship at the University of Michigan College of Pharmacy. Post-training, Dr. Manzor has continued her experiences at the University of Michigan as an assistant professor and ambulatory care clinical pharmacist. Dr. Manzor has a significant impact in research and has had numerous publications. She continues to extend herself through multiple professional organizations as well, such as with the National Hispanic Pharmacists Association being one of them. Dr. Manzor doesn't stop there, but also focuses her efforts on anti-racism, DEI, and ensuring she's fostering the growth of young professionals through mentorship. So with that, I will hand it over to our speaker, Dr. Manzor.
Thank you so much for that introduction, Dr. Serrano. Next slide, please. I have nothing to disclose. Next slide, please. Thank you. So today I am so grateful to be here with you talking about this very important topic, which is depression care in Latino or Latina population and how social determinants of health intersect with that. And I'll be covering these 3 items specifically, which I'll highlight as we're going along in the presentation. Next slide, please. First off, I wanted to start off with some terminology because, as we know, words are important. And because depression is associated with stigma, and that stigma associated with depression can result in people not seeking care or not even understanding that they have a condition where they could get treatment. And so because of that, it's really important to talk about words and terminology. And so as I'm using these, and hopefully this creates sort of an understanding of the words that I'm using and the intent during this presentation. So as a researcher, I use the term Latinx, which is an inclusive word, a term for people who are Hispanic or Latino or Latina. It is often used by people who speak English because the X is something that's easy for us to pronounce if we're English speakers. And then for those who are Spanish speakers, the Latine is a preferred term. And specifically also in research and academia. In general, I find that most people who are Latino or Latina are comfortable with that term as well. Also, I wanted to mention that ethnicity is a social construct that is how people are categorized or grouped, and that it's a social term. So there's actually no genetic specific gene or groups of genes that have to do with ethnicity. And I'm happy to have that conversation with people about that. And then there's ancestry. Sometimes people think those things are the same, and that has to do with your ancestors and where they came from, and that there are genes that we can link back to your ancestors. And same as ethnicity, race is also a social construct. Next slide, please. I first wanted to start off talking about depression, scientific data and evidence that we have about depression and its management, and then also talking about social determinants of health, inequities related to that, and how that intersects with the Latina population. Next slide, please. First of all, it's important to know that depressive symptoms, which is what we are assessing in most national surveys that go out, those are relatively common, reported among Latinx, Latina adults in the United States. And so we see a variation of between 6 to 38% of adults that will report that, depending on the survey and the group that's being surveyed. When we compare this to people who are not, they're non-Latinx or non-Latina white adults, we actually see that there's a similar incidence when we're doing comparative surveys, or both populations are being assessed during that survey. In that we also, key differences are that the Latinx adults are up to 50% less likely to seek care for their depressive symptoms, and that also they're more likely to have severe depression, or what we call, and what I'll be talking about mostly for this presentation, is major depressive disorder. Important to note is that the World Health Organization reports that mental illness related to stigma is the most substantial obstacle to seeking care for all populations with depression. Next slide, please. Also, and I think everyone is aware that one of the most serious outcomes of depression is death by suicide. And what we know about the suicide mortality rate among Latina individuals is that it's actually lower and one of the lowest when we're doing comparisons of different populations in the United States. So you can see for someone who is white and non-Latina that their the rate for age adjusted for death by suicide is a little bit over 15, and whereas it's just under 8. Still, of course, any person that has a death by suicide, obviously that's very serious and concerning, but that sometimes when we look at outcomes related to depression, I think that there may be a focus on this outcome, which it is important, but it might somehow seem that it's less of a concern, depression is in a Latina population. So, but now what we're seeing trends that were prior to COVID. There was similar rates of suicide attempts or ideation, and now and we saw that decrease. Then we've seen it go back up, and unfortunately now we're seeing increases in young adults, and so anywhere between age 10 to 24, we're seeing an increasing rate of risk of suicidal ideation and death by suicide. So, and also I wanted to note, because this is really important, is that some of the reports that are looking at the rates of depression or people reporting depressive symptoms is that it may be that there's an underreporting of these or a lack of screening, as well as several complex social issues, which may be why some of the rates of depression as well as suicide and mortality aren't necessarily being connected to suicide. And then finally, and this is something where we could come in and really take an active role, is being aware that attitudes by healthcare providers may actually not encourage and in fact discourage individuals who have depression or have suicidal ideation to actually share those thoughts with their healthcare provider to see if there's some support that they can get to get on the other side of that ideation. Next slide, please. So really important is an awareness of that there are various types of depressive disorders. And that today I'm going to be talking about specifically major depressive disorder, or MDD. MDD that lasts for a 2-year period is considered persistent depressive disorder, or some other types could be turned into persistent depressive disorder. And I say that specifically because I do feel that many times when I am seeing patients that they don't really have a realization about their symptoms until we have specific conversations about that, and that it may be that they've had these symptoms really for more than a year or two. So, and specifically MDD is when somebody has symptoms, which I'm going to share with you in the next slide, and that those persist for 2 weeks or longer. Next slide, please. This is the diagnostic criteria for MDD, and I share them with you for awareness, and I'm going to also share with you the screening tool. The reason I do that is because as pharmacists, there are community pharmacies and other areas where pharmacists practice that we use this tool to identify people who may be at risk of having depressive symptoms, may not be aware of that those symptoms indicate a disorder or an issue, and that and then we can, of course, the best case scenario is to identify people who are having those symptoms early on and to make interventions before any actions are taken or before they've had these symptoms for a long period of time. And so I wanted to share those with you specifically, and then I'll point out some of the differences between how the Latin group tends to present in general compared to other populations. But specifically, people will have at least 5 of these symptoms of low energy, of depressed mood, diminished interest or loss of pleasure, which is anhedonia, weight loss or weight change, sleep disturbance such as insomnia or hypersomnia, and psychomotor agitation, as well as fatigue, feelings of worthlessness, diminished ability to think or concentrate, and recurrent thoughts of death or recurrent suicidal ideation. So, and that these are happening within a 2-week period, and at least one of the symptoms are one of the ones that are highlighted there for you on the slide. Next slide, please. This is a common tool that is used to help either screen individuals for depressive symptoms. It is also used it's part of a diagnosis that's done by a physician, and it can be done by a primary care physician or can be done by a psychiatrist. And then it is also a tool that's used to monitor people over time as they're getting treatment and to see if that treatment is effective for them. I highlighted here because I wanted to tell you that sometimes we'll do something called the Patient Health Questionnaire 2, which is a 2-item, which is the first 2 items on the questionnaire. And I apologize if I see it now, it's a little blurry, but if you Google it, you can get a PDF, and I'm happy to provide a link later if somebody is having some difficulty finding it. But it is a really helpful tool, and it can be built in. I know that there are community pharmacies having that, where they ask people regularly these questions because it's a way to identify people at risk. And then if it's a positive answer to any of those 2 first questions, then it'll prompt it should be that you prompt somebody to answer the rest of the questions, and it's a PHQ 9, so 9 items, and that will actually identify quite a few it'll identify the majority of individuals. And so you can see that if they have a score of 10, which indicates moderate to severe depression, that it's actually quite sensitive, about 88% in most populations tested, and it's quite specific for MDD or major depressive disorder. And they also have questions that ask about suicide, and so I'll talk a little bit more about that as well. Next slide, please. So here is how this questionnaire would be scored. And so there's even like tools where you can have people take an online application or use an online app or an online source of taking this questionnaire. And then it'll, it's not that this should be telling people specifically you have severe depression or that type of thing, although some people may want to know that, but it is a tool that can help them for awareness of where their symptoms are and if they're having symptoms that are worsening or not. And it would be, I think it's surprising sometimes the when you have a conversation with somebody and you tell them like, well, this is where you were and this is where you are now. And I think that helps people be more objective in their assessments. Sometimes it's maybe just for whatever reason, difficult to remember how that was and where they are now in those contexts. So most, as I'd mentioned, a lot of, it's more common, I should say, for Latina individuals to present with more severe MDD, which is a score of 20 to 27. 27 is the highest you can score on this assessment. And that for somebody to be improving on therapy, they actually have to see a reduction from that baseline. So if the idea would be that you would do a baseline assessment and then begin treatment, hopefully, and there's lots of different treatments that I'll tell you about briefly, or different variations of ways to get to management of depression, and that then to see somebody actually go into the goal is for them to have less than 10, which is to be mild or indeterminate for that, for their score on this assessment. And just one last thing about this slide I wanted to mention is that there are questions about, it's item 9 that asks about suicidal ideation, and that really important to understand the findings around that question. So first of all, if you're going to ask that question of individuals, I really suggest that you have a plan. When I ask those questions, I'm in a clinic or I'm in, I have a, literally, it's called a suicide ideation plan. And so if somebody answers positively to that, that item, then I will enact that plan. Like I will initiate following it, which involves calling either somebody in the clinic if I have access to that, but also calling depending on what is how it's being stated. So we have like levels of how we would start to help that individual if they need to be bridged to more supportive care or based on what they're saying. So I say that, and I don't want to say it like, I mean, it's something that as pharmacists we may encounter, and I've talked to a lot of pharmacists that it's somewhat surprising how many times they may have interacted with somebody who says something that, or they've answered yes to this question. And so having a plan on how you're going to address that and giving them supportive support, and then additional support if they need it beyond that. So important to remember though, even if they do have, a high score or a positive score on this question, that they may never actually attempt. But in some cases, they may score not at all, which is like a negative score on that item, and they may still attempt or have a death by suicide. So, but we do know that overall, it is a good indicator for somebody who may be at risk. So we would never dismiss if somebody answered positively. We would want to have some, take action on that. Next slide, please. These are the phases or an idea of what the phases of MDD could look like. And there are a lot of pieces to this, to MDD and its treatment and the expectations. I want to highlight for you what is the person's baseline mood, or here it's indicated as normal mood, which is on the far left of the slide, and that you'll see that the severity of depressive symptoms are going down, or I should say going up, even though the arrow is going down. And so meaning that you're going from starting to have symptoms to having perhaps being diagnosed with MDD. And so we see that change in people's symptoms. And so we would really want to capture people as they're, and by doing screenings before they're actually having severe symptoms, and then initiate treatment, which can be antidepressants. It could be also initiating cognitive behavioral therapy or other types of psychotherapy. And usually it's a conversation with people to see what they prefer. There are some data that I think are a little bit older that would indicate that people who are Latina, that they prefer psychotherapy. And if anybody has any feedback on that or experience with that, I would really want to hear your perspective. And I don't disagree with that. But I also know that because that can be complex, and this is now sort of starting to talk about some of the social determinants of health inequities, is that they're because of somebody's schedule for their job or getting transportation to the clinic to do something that perhaps if it's behavioral therapy, which is what we found in earlier in the literature that people said that they preferred to do, and is really a really important piece of treatment and management, but that it would be it's just difficult for them to navigate because of the complexities of their work schedule, and if they do their type of work or whatever that is. And so fortunately, we have telehealth, which has improved access for some people, but videos, doing video visits and that type of thing may still be make those not accessible to certain individuals. So things to consider then when we're trying to help people who have depression or MDD and trying to get them to the therapy that helps them be successful. And many times that is prescribed in conjunction with an antidepressant. And so as pharmacists, we can ask about symptoms, and we can ask about with the PHQ-9, and then we can also ask about side effects and adherence, or what I prefer to say is, how have you been taking it? Have you missed any doses? And what might be the reasons that you've missed a dose? And sometimes it's cost. Although antidepressants tend to be less expensive, there's still it still could be a barrier based on all the other expenses that individuals have. And then also just access. Are they able to get to the pharmacy? And other issues that I'm going to highlight as we talk about some of our questions. So I just wanted to present this to you because I think it may be surprising to some people. I think often people, one of the biggest, or I think most important data points that when I think about management and success for depression treatment is that a large majority of Latina individuals, something like 30%, never have their antidepressant prescription filled, even though it's sent electronically, they never pick it up. And then like another 30% or so actually they may start it, but they never finish out that 90-day course. And in fact, if it's prescribed every 30 days, we know that measurement of that 30-day, and then after that they don't get a refill. So that is an important time point for pharmacists to take action, perhaps, and support individuals so that they can, find out the reason perhaps that why somebody hasn't decided to continue to take that medication. And then also important, I think, to note is that what the data show is that it can really take with an antidepressant and therapy, it really can take 12 weeks for somebody to, or I should say about 4 to 6, or actually 6 to 8 weeks to see a response, and from an antidepressant in particular, and then for them to get to the point of what we would call remission, remission meaning that that they actually, their symptoms have gone to below 10 or back to their baseline. And then, from there, a continuation really in many patients to a year, really, and sometimes more to prevent and maintain them in remission, or to the point of recovery. So really, we're not talking about recovery from depression until they have been really it's 9 months into that course or that time frame after they've achieved remission. Next slide, please. So it can be really challenging to actually measure the PHQ-9 or measure depressive symptoms, as I'd mentioned about with death by suicide and the mortality rate, and how with the last item of the PHQ-9. So, and other variables can be that symptoms can change day to day, that's just normal human emotions, but also the intensity can vary. And so that can also make it sometimes challenging to assess if somebody is responding to the treatment that they've been prescribed. And also, as I gave you those numbers, like less than 10 and those types of things, those are some those are guidelines, but even those really have those numbers and those changes can be experts still dispute them and say whether or not that they're going to be, that how accurate they are. So really it still has to be, as much as we say numbers, we're treating patients, and we want to make sure that even though somebody may be saying that their symptoms are and taking that the PHQ-9, that their symptoms are less than 10, but if they're still presenting in a way that indicates that there's a disconnect between what's being filled out on the PHQ-9 and how they're presenting or how they're speaking to you, then it's always important, of course, to take all of that into account. Next slide, please. So some of the symptoms of depression or depressive symptoms I wanted to highlight to you that we may see more are reported up to twice as much or more often in an older, specifically Latina population, and this is compared to a non-Latina white adult population, are sadness, anhedonia, which is the loss of pleasure or desire to do the things that they normally like to do, and psychomotor symptoms, which are a lot of more symptoms that may be disconnected actually from what we would think are depressive symptoms. So pain, the stomach issues, gastrointestinal issues that may not be very obviously connected to depression, but after a workup, we might not be able to find any sort of reason that they resolved, or they may spontaneously resolve that. So sometimes that complicates the presentation. It's the same thing with sleep disturbances and guilt, that those have been shown to be up to twice as more common. Next slide, please. So here's our first question. And I'll read it off, and I'll read off the answers, and I'll give you a chance to answer in the chat. And I'll try to see if I can actually see your responses in the chat. And but I'll give you a minute to do that. So which depressive symptom is reported twice as often by older Latina adults? And it's more common than in older non-Latina white adults. Is it fatigue or loss of energy, loss of interest in almost all activities, hallucinations or delusions, or weight changes? Oh, I can see it. Great. Okay. So I've got a few responses. Thank you. So great. So I'm seeing the responses, and everybody is answering. Next slide, please. B, which is the loss of interest in anhedonia. So yes, that is actually seen almost actually over twice as common in that population. And just being aware of that, I think, helps us have a better understanding. Thank you. So the next objective then is to talk about the intersections of depression management and the Latina ethnicity. So next slide, please. First of all, I wanted to start to talking about what's a health disparity, and letting you know that there are somewhat different definitions of what a health disparity is. And so I've highlighted some key points just to keep in mind, because I think that helps us understand how health disparities align with what we call social determinants of health. And so, a health disparity is when there's a difference between two populations, and it's usually a dominant population and a population that perhaps is underrepresented or is in some way socially, economically, or environmentally disadvantaged. And so again, this is a difference in their health. And that most importantly, that this health difference is preventable. So it's something that we know that we can treat, or we know that that doesn't have to happen. Next slide, please. Intersectionality and why that's important is really where, and I think it's really key, because while all of us know that we're not just one dimension, that we have multiple we're complex people, and we have multiple identities and ways that we orient ourselves. And so what happens is that with certain groups, that they may be underrepresented as an ethnicity or a race, but then they also fall into other categories, which may actually make their outcomes worse, because they also have perhaps things like not speaking English very well, or have a mental health disorder. So all of those things that are associated perhaps with what we would say are discrimination and or forms of oppression that will actually impact their ability to get care, seek care, and recover from their disorder or get treatment. Next slide, please. So, okay. And then also talking, I wanted to share a quick little case with you about an individual who is a non-English, Spanish-speaking older woman, and she's taking an antidepressant for depression, and she keeps this to herself. The prescription medication label is written in English, as is the information sheet provided with the medication. After 3 months, she stops taking the medication because her bottle is empty. So she'd been given a 90-day supply. And then within a few days, she begins to experience something that is called antidepressant discontinuation syndrome. Some people may say it's withdrawal, and some, which it is not. They're not withdrawal symptoms. And so, but in her case, she attributes it to something called mal de ojo, or evil eye. And so in some groups of people that they have these symptoms as presented below that overlap with what antidepressant discontinuation syndrome is. And sometimes this is because of, well, it is an abrupt discontinuation. Sometimes it leads people to think that the antidepressant was bad for them. And sometimes they will see a dramatic worsening of their symptoms. So really important to take into consideration, because I've tried to point out, hopefully you'll see here, quite a few ideas about inequities for this individual, being that her label's in English, but she speaks Spanish and reads in Spanish, and that maybe she didn't get the counseling she needed, that she needed to continue her antidepressant, and no one explained to her that abruptly discontinuing it could lead to some serious side effects. Next slide, please. So this is a slide that I wanted to share with you because this is a framework for social determinants of health. And if I didn't mention it, it's the where you live, where you work, and how all these factors of your environment influence your ability to have good health and the best health that you possibly can, which is health equity. And that's for everyone, right? So when there are inequities in this or differences between groups, then we say that there are, health disparities, and that what we know of the data and science is that these disparities typically occur because of racism or discrimination when we look at different groups like Latino individuals compared with other groups. And so on the next slide, I share with you some highlighted health disparities that are related to determinants of, and specifically mental health. And I touched on a few of them. I've touched on stigma and whether or not someone would seek care. I've also talked about language. Education may be because many individuals in the United States that are Latino came from or were educated in a different country, and not that they may have received a college education, but sometimes that education when they come here it's a different education, or they may not be educated or understand how our healthcare system works. So sometimes there's a disconnect there. And as we all know, our healthcare system is pretty complex. So that takes, that could be a learning curve for somebody to be familiar with that and learn about that. Many times with the employment that some people will have, I mean, that happens in the United States as well. There's no healthcare coverage, or they can't take days off. And so that can influence whether or not they have access to care. And then, as I'd mentioned previously, there is the lack of having linguistically concordant, meaning somebody who speaks Spanish or having access to an interpreter, or culturally concordant, meaning somebody who the patient feels comfortable speaking to because they understand their culture, and they also, represent their culture in a way so that they feel comfortable speaking to them, and you have a sort of rapport established. And the last point too is that many times people are in many situations we're seeing, especially now, especially with a lot of conflicts that are happening in different countries, that we'll see that people have experienced violence or trauma, or know someone very close to them that has. And so then that can also be something that may influence their mental health and their ability to seek care. Next slide, please. So these are the risk factors that I touched on, but they are specific to a Latina population. So recent immigration, what their immigration status is currently. There could be generational conflicts, beliefs that what people, perhaps one generation thinks is just, life and what their ancestors or, their parents went through and what they're going through. I'll hear things like, well, I don't know why, they're having such a difficult time, referring to their children. We brought them here and this is a much better situation than what I have. So things like that. So like a disconnect, and can make it really difficult for somebody to seek care, and just really make it very just difficult in general. And so of course, it's just, like I said, like intersectionality and an additional barrier to seeking care. And then medical mistrust, I wanted to touch on that just because I think a lot of times when people are referring to that term, they're thinking about that the person not trusting a healthcare provider. And really what literature has shown is that the individual, the patient, has a reason for feeling uncomfortable or feeling that the person, the healthcare provider that they're interacting with, does not have their best interest in mind. And unfortunately, we have lots of examples of that currently when we look at disparities and we look at discrimination and racism, and so in healthcare. So really, it's a matter of a healthcare provider understanding that and doing their best to establish trust. Next slide, please. So I know I've touched on a few things, but I really want to focus specifically about disparities and what we can do as individual pharmacists. So when pharmacists do amazing work. I talk to pharmacists all over the country. I've been so fortunate to hear wonderful things that pharmacists are doing to support their patients and support people with depression and support the Latino population or their communities. And I think that's really important. So things that we do at a personal level or an interpersonal level are really important. To address disparities, these are things that are happening at a systemic or structural level. Those things really require us to make changes at those levels then. So it's making changes to unfair, unjust laws, policies, things that are biased, things that may historically have been done, and we just accept them because that's how it was or how it's been. And hopefully after learning about some certain things, some things, if you weren't aware, is taking a look maybe at your policies and things that may, or your procedures that are done that you have access to or can make a change about, that would actually improve access and that type of thing, so that you would have an ability then to really address a disparity at that level. Next slide, please. So I want to, the next two slides are really touching on barriers to seeking care for depression. And I've touched on a few of them, and so I'll just go through them a little bit faster for this slide. But as I'd mentioned about cognitive behavioral therapy, there's a feeling that they don't have time for it, or it's less effective, or whatever they're taking isn't helpful, or they don't need it. They do other things that they feel they're comfortable with, that'll help them. And that's not necessarily a bad thing. I think that it's really important to find out what people think is working for them, and then see, give some sort of objective measure to help them understand if it is working or not. Next slide, please. And then as I've talked about stigma, sometimes when we talk about myths or stereotypes, it's many times it's misinformation, and it may be that it comes from a friend about if something is I heard that doesn't work, or I heard that it changes your personality. I heard sometimes these are based in some, not necessarily fact in that case, but that something that happened. And so there's a grain of fact, but that perhaps there isn't like a frequency or a severity, or like what is it that could have been done to prevent it. Those kinds of context that as healthcare providers that we can help people navigate this and get the best effect out of whatever's being prescribed for them. Next slide, please. So here's our second question. And so go ahead and show me what your answers are. So which of the following is not a social determinant of mental health inequity specific to Latina individuals? Is it assimilation, language concordance, acculturation status, or stress related to immigration? Free to put your information in the chat, or your answer in the chat. Okay, so we'll go on to the next slide. So I'm wondering, I'm not seeing very many answers, and it could be because I didn't say what assimilation was. I haven't talked about it. So maybe that was an unfamiliar term for some people, but so assimilation is the process whereby individuals or groups actually their culture is absorbed into the dominant culture, they take that culture onto themselves. And so that really is not actually associated with social determinants of health, but something called acculturation can be. And the variations in it, the degree. So if somebody has assimilated, they usually will have not have the same issues, not have differences. But definitely, as I'd mentioned, language concordance and acculturation status can as well, and the stress related to immigration. Next slide, please. So next, the last objective then is to talk about some practical solutions, and then as a way to reduce disparities and help us with the care of these patients. Next slide. So things that we can do as healthcare providers, as I had mentioned, that there's concerns about medical mistrust and also concerns about stigma, even that as healthcare providers we might have. So there are still quite a few healthcare providers that still may feel that somebody isn't maybe being sincere about their symptoms, or that they're exaggerating what those symptoms are. So it's really important to take people where they're at and understand that the importance of having rapport and people feeling like they're being listened to. Sometimes that requires us to get additional knowledge, understand how to treat depression and the management of depression, as well as if we don't have interactions with people who have mental health issues or specifically depression, finding ways where we can get interact with and find out like how prevalent it is in our community, and interacting with those individuals to find out the care that they need. Next slide, please. So at a personal level, there's things that we can do is be reflective and use mindfulness, which is really having an understanding of ourselves and our thoughts, and maybe thoughts that may make it difficult for us to be more empathetic to individuals. And that's a lot of that is really our history. We are a product of our upbringing, but then also we have the ability to have awareness and make changes in the way that we think about things. Next slide. So these are really the key points, is that making sure that when we speak, we avoid using stigmatizing language, which is using words that are maybe slang terms for people who have depression, or being disparaging of people who have those symptoms, or minimizing people's symptoms. If someone is saying something that implies, sounds like it's stigma or a stereotype of these individuals, making sure that we actually call that out, and listening to people who have these symptoms and helping them if something isn't working for them, try to find alternatives, and really sometimes it's giving people space to figure out, what's the right time for them to engage in care, or let them know the seriousness of their symptoms and that they should seek care immediately. As pharmacists, we have access to medication information that we share with people. As I'd mentioned in the one case, is making sure that information is written in a way that people can understand it. So that could be in language, if it's in Spanish or English, depending on what the person prefers, what they understand, and that it's culturally concordant. So there's a lot of rich literature that has shown that some of the information, how it's presented, people don't think it really relates to them. And so they don't necessarily take it to heart or pay attention to it. Next slide. So hopefully everyone is familiar with the 988 suicide and crisis lifeline. It is a 3-digit number like 911. However, this number, it connects individuals directly to a mental health professional. They are they have an opportunity, or have access, I should say, to Spanish individuals, like people who speak Spanish. You can call, text, or chat. It's available 24 hours, 7 days a week. And for people who who use American Sign Language, then there's a video option as well. And so they can do it online. And so one thing, though, to note is that if you are helping someone or you recommend to somebody to call, to use this number, which actually I recommend that you do in any case. I always am sharing that information because you never know when somebody may need it. But to let them know that that it's really important to tell people on the line where you are, because what they'll do is they'll route the call to whatever the area code is that is from the phone number, and that person may not physically be in that area. So that's one of the things I think they're trying to work out, to make sure that they can actually locate somebody so they can send them care directly. Next slide, please. So here's our last question, and it is about the barriers and how we can reduce barriers to depression care. So which of the following could reduce barriers to depression care for Latina individuals? Is it A, expecting patients to trust healthcare professionals? B, not taking action to point out information that could be perceived as a stereotype? C, language discordance? Or D, culturally specific health information? So which of those could reduce barriers? Okay, all right, so I'm seeing some letter D, so next slide, please. So I feel like I've really touched on the points there, so that was it. Everybody was able to understand that important point. So yeah, so very much important to have information that is presented in a way that people can relate to it. Next slide, please. So I really appreciate all of your attention as I go through what can be sometimes a very difficult topic for people to talk about or understand, just based on how we were raised and also individuals that we're treating. So it is actually very common to have symptoms among for Latina individuals as well as the population in general. So this isn't something that is a rare disorder. And so awareness of it is really important, as well as knowing for Latina individuals, especially now what we're seeing in the, we're getting lots of alerts, is that to be aware that Latina individuals between the ages of 10 and 24 are seeing almost a 20% increase in the rise of death from suicide. The influence of stigma and intersectionality and inequities really make managing depressive symptoms more difficult, and also make major depressive disorder more difficult to diagnose and manage from both sides, as a healthcare provider and from a patient's perspective. So there's lots that we can do as healthcare providers to really improve interpersonal interactions and help address disparities that are happening at an individual level. And there's also things we can do to address inequities by voting, by looking at policies that and bring it to attention to our directors and our supervisors, issues that we've identified, so that we can make changes to things that are happening within our organizations or across the system in our government as well. So I really appreciate your attention. Next slide, please. And I have some resources that I touched on the 988 number, but also some other resources that I think might be helpful for you. So it's available in Spanish for that you can share with patients that you might be interacting with. Next slide. And here are my references. And I really thank you for your attention. Are there any questions for me?
Thank you so much for that presentation. It was so well put together, and we learned so much from it. I don't currently see any questions in the chat, so I will open up with one. And while I do that, I'll allow everyone time so they could enter in their questions into the chat. But I wanted to start out with the number that you presented that I was really shocked by. About Latinx adults are up to 50% less likely to seek or receive care for depression. That was astonishing. And so I wanted to know, what other things can we be doing as pharmacists to be able to recognize, that patients need to seek care, and that we are able to see it without them telling us?
Yes, I think thank you for that question. And it is, as we say that number, it is dramatic, and it is accurate in certain populations. So it's not to say, as we know, right, being Latine is not a monolith, that there's a lot of differences in individuals that are within that group. But we do know that it's sometimes within an older population, or sometimes within so it's knowing that in some cases, like as you're talking to somebody, you could try to have an understanding of like as they're speaking to you, as they're saying things about their treatment. So sometimes there are clues in that. And as I'd mentioned, I think it's really important, if at all possible, to try to do, like, if they're not talking to you about things or not sharing things specifically, you could look at sometimes we'll look at records of how many times they're getting their antidepressants filled. If you have access to that information, or if you have access to more of an EHR, you could look in the EHR and see if they've had follow-up on their behavioral health visits. I often just really try to, I see patients mostly for diabetes, and that's a comorbid condition that is actually can be made worse with when somebody has, or more difficult to treat. So I'm often, if somebody is telling me how difficult it is, and if they are presenting in a way, I will do a PHQ-2. I'll ask them those two questions, or just show them and ask them to tell me what their answer is, and then I'll refer them for behavioral health services. So I think there are a lot of ways, if even though they may not be like telling us, I don't want to take that, or I don't like it, there are other things that maybe people are saying how they present with, maybe they are normally very, wearing makeup, or have, they have clothing that is clean, and then they're presenting not that way. That's a way, or perhaps they should seek care at the beginning, or if they present like that over time. So those could be some clues as well.
Got it. And, I think you said something that was really profound, is being able to connect with concurrent disease states. And so maybe that could be the launching pad, is being able to identify, a comorbid disease to where it could put them more at risk for depressive states. And so then we could go from there. Yeah, that's really great. And then you had also mentioned about including the PHQ-9 in community pharmacies. And one thing that I think many people do is they'll do it, but like you encourage, what is your plan after? If someone unfortunately does come with a plan of a suicidal ideation, we also have to have a plan to act. And so I think we could, as a take home today, is making sure that we have that, plan of action for our own, ourselves, so we could be able to help them the best way. Okay, great.
Absolutely. Yes. And I actually, to just add on to that, I know that there are different studies that have been done. And so obviously you're going to need support from your leadership, but it has been shown to actually really help individuals. So a lot of people that may not have, that could have maybe fallen through the cracks, got care. So I think as long as there is a policy, there are enough Good Samaritan types of laws that will, and as a healthcare provider, that should bridge that, because sometimes people worry about liability. I'm not sure if people are thinking about that in general, but I know that that could be an issue. So just letting people know it's been done. And so maybe connecting and getting that information out there would help people, more pharmacists be able to do this service.
Right, right. Yeah, so I think part of this astonishing number, I think, leads back to disparities in the
Yes.
Latino Hispanic population.
Yep.
You know, whether that's access to medical health services or something else. What is that something else that you have seen?
So I think you're correct in that you touched on access, so being financially able to afford treatment or get care. Stigma is also, I think, a big barrier, that perhaps they're not getting support from their family members, or their symptoms are being dismissed. I think there's much of an attitude, very much like resilience of, just getting over this hump or whatever people might attribute this certain event that happened many years ago as to the reason they have these symptoms. And that can never be resolved, so they can never get better. So sometimes it's the context. One thing that I really found, when we're looking at, if we want people to take medications the way that they're prescribed, and we want them to have the best chance of actually getting the effects good effects, it's providing information to them in a way that they can understand it and read it. So if they, sometimes it's images, sometimes it's having access to information that's a video, or it's auditory, or verbal. Those things, I think, help bridge some of those inequities that we don't maybe necessarily think about, or we feel like, oh, it's not that big of a deal, or I don't have time for that. So I talked to a lot of people where that's the difference. They just stopped taking it because they couldn't read the label, or they didn't know that they had to. So sometimes it's just really that me simply saying, no, you have to take this, and maybe some of your symptoms were because you stopped taking it so quickly, and all those symptoms came back, and now they may feel like they're worse, but honestly you were just getting better. And so it's this very abrupt difference. So a lot of times it's just having that conversation.
Right. Okay, so we are approaching the hour. And so I want to be respectful of everyone's time, but most of all, I want to thank Dr. Beatriz Manzor for being so gracious with her time and presenting on such an important topic, and being able to share her knowledge with all of the pharmacists and individuals who are on this presentation today. It was so great, and always a pleasure to have you, Dr. Manzor. If we can move to the next slide.
Oh, yeah.
Okay, so for any kind of updates that we have are listed here on this slide. We do have an upcoming webinar, which is going to be on COVID-19 updates and also on vaccine updates with Dr. Carrie Hurley. That presentation is going to be on December 12th at 7:30 p.m. Eastern Time. We do have an NHPA newsletter that will be coming out on November 21st. If you would like more information about the National Hispanic Pharmacists Association, if you are not currently a member but are very interested in joining, please go to our website and you could be able to find the information there. In addition, thank you for changing the slide. We do have the QR code for our website, as well as the post-webinar survey, where you'll be able to obtain the information for your CE credit as well when that's going to be emailed to you. Thank you again, everyone, for your time. Have a great evening.